welcome everyone to Khan Klinics. Today we're diving into two very important aspects of healthcare issues that touches almost everyone. One, end-of-life issues. The other, palliative medicine. End-of-life issues encompasses those challenges and those decisions made by individuals or family as they approach the end of life for their loved one. The second topic which we're going to touch on is palliative medicine, something that really has changed the landscape of healthcare medicine in the United States. Not only does it focus on symptoms and stress that is associated with serious illness for your loved one, but the aim is to enhance that quality of life for the patient, and not only the patient, but the families as well. It's more than just taking care of those physical symptoms, but we have to address the emotional, social, and importantly, the spiritual needs that goes along treating as a standalone approach. Together, these areas form a comprehensive approach to care, to patient's dignity, to his comfort, or the support during someone's life and the subsequent challenging times. Today, we're very thrilled to have a specialist in this field with us, whose insight and expertise we're going to benefit a lot. So I want to first of all welcome Dr. Karl Lorenz, who is a leading expert in end-of-life and palliative care medicine. Dr. Karl, welcome.
Thank you. It's a great pleasure to be with you.
Just a brief intro on Dr. Karl Lorenz. He's not only an internal medicine physician, but also a palliative care specialist. He's the chief at the VA Palo Alto Standard Palliative Care Program. Formerly lived in LA, Dr. Lorenz directed palliative care research at the VA for innovation and implementation and served as the faculty at the UCLA School of Medicine. He's a member of the VA National Hospice and Palliative Care Program. He's also the director of operational Palliative Care Quality Improvement Program and adjunct faculty staff member at RAND. So we've got a fantastic and a very well qualified person for the topic that we have today. The media team is going to play first a brief intro on end-of-life issues to get ourselves started, Dr. Karl, and then we'll take up the discussion from there.
Sounds great.
Finding out that somebody you care about is going to die can be very difficult. Even if you've been expecting the news, having somebody actually speak it out loud can have a devastating impact. Life as a carer can be extremely rewarding, but also both emotionally and physically exhausting. And there are very few of us who are able to get through such difficult times without the support of friends or family, or from healthcare professionals who can be with us as we travel the road. Carers can take comfort from knowing that others have travelled this same road, and that while each family and individual is unique, your healthcare team can provide really useful information from their training and their experience of having travelled with others. Watching somebody that you love approach the end of their lives raises all sorts of questions. Are they suffering? What can I do to help? Can they still hear me? Are they starving? What's going to happen next? Having somebody who can help you find answers to these questions can bring real comfort as you do your best to care for your loved one. Even when your loved one appears to be sleeping or resting, they still are often able to hear you or be aware of your presence. Holding their hand, reading to them, talking about happier days and happier times, or playing their favorite music may be comforting for both of you. If you're caring for your loved one at home, you will have the support normally of your own family doctor, GP, and your community nurse. Other health professionals may also be involved in trying to support you, such as the social worker or the specialist community palliative care team. These people will aim to respect the wishes of your loved one regarding their treatment and care, but also to respect your needs throughout your caring work. They will continue to be there for you after your loved one has died to provide practical information and ongoing emotional support.
So fantastic. I think that is a brilliant video that set the stage for Karl to come in. And we see this in the hospital, which is the most frequent setting, and sometimes it can be as an outpatient, which is in a nursing home, where you're seeing, we as physicians see that, boy, this is the end of the road for this patient. We've done what we could do. And there is a next step. And the next step is, as a physician, we want to say, what is that we can do now for the patient? Karl, how do you go about in the room and start that conversation?
First of all, we want to start with what the patient and the family understand themselves. And so knowing whether they understand their disease, its implications for their prognosis, what they're likely to experience from that illness, and what the care plan currently is really an important place to start. Another really important understanding to have is the perspective of the patient with regard to wanting to know more information. We're providing information. We hope that our clinical partners in whatever setting we're in have already started that process. And, when we're sharing difficult news for the first time, we really want to have those other important persons there and not provide too much information, because that news can be very difficult to absorb. But building a relationship with the family, recognizing that we're going to be an advocate for them, we're not an advocate for some other external party, and that really trying to understand what their values are is our goal, is an important starting place for those conversations.
That's, I think, a brilliant answer. Why? Because I think you've gone in and you're assessing what does the family know first, and you're also looking at what their expectations are, and you start sort of like an expectation dialogue, and then understand that, do they understand that this is the final moments, or the final um, essentially the final times that they're gonna have to have their loved one go, and developing that relationship, like you said, and giving that information out in little bits sort of sets tone that we're going to address this one by one.
I strongly agree with, and I really appreciate the fact that you mentioned the nurses. I mean, one thing that's true about our team and about the ICU team or whatever other team we're dealing with is that our visits are episodic, but the nurses are there 24/7, and often they're the ones who are really partnering with the patient and family closely. And yet they're often disempowered in these conversations, so we always want to present the nurses as part of the team. And we often, with palliative care service, we'll have a chaplain, we'll have a social worker, maybe trainees with us. So we want to be there with the ICU team, with the team that's going to, our team that's going to represent itself to the patient, but also to with nurses, the nurses who've been at the bedside, really seeing the patient through that part of the journey so far.
Excellent. And I just want to clarify this to the audience here as well. I know you guys are writing, yes, it's a very tough situation, but know that the team that is going in it's also tough for the doctors to, and the nurses and everyone else, to break that news. Dr. Karl is pointing out that they go with a social worker and a religious scholar, the chaplains being there to make sure that the spiritual needs of the family and their religious beliefs are addressed appropriately. And that's also a very important aspect of why everyone is going in this discussion. And a lot of times when we are making that decision, it's really a family, it's a lot of the medical doctors, and we're making that decision as a unit, and it's not just a doctor's call or an ICU person's call, but it's actually a combined effort on trying to address all concerns one have. Karl, give us an example. How would you go about addressing that issue when you have an older son and a younger daughter, or an older daughter and an aunt, who right in front of you are like disagreeing that, no, this is not what we want to do, and we want to go about it, continue pursuing what we want, and we don't want you to stop medical treatment?
That's a very, very difficult situation. And I think it gets back to the point that we always start with the patient. The patient needs to make an important decision at some point, which is really how they're going to be represented by others, who's going to help them make those decisions and arrange for the care that might be necessary. You know, what we always try to do is really help everyone understand the voice of the patient. We also want to listen to everyone's perspective. I think a lot of times that situation may arise when someone who hasn't been involved in the individual's life comes from a distance. Maybe a child's been living overseas or is somehow disconnected from the situation. So information definitely is part of what we provide, but our role is always to support the patient and to support the patient's perspective, and that's going to be our starting point in trying to resolve that difficulty.
Thank you for that answer, Carl. And we are an advocate of the patient, not an advocate of death, so as to speak.
The other thing to realize is that we all have to grieve, and I think a lot of times that resistance, which can come from us when we're ill ourselves, when we're the patient, but it also comes from the family members and sometimes it's expressed in ways that maybe don't reveal the underlying grief, but often that resistance is really because it's so hard for us to see what is right in front of us, which is losing someone that we really care about and love. And so respecting those emotions, giving people a place to grieve is an important part of resolving those roadblocks.
Brilliant. You brought up another brilliant point, because a lot of times we think that grieving, crying, or being sad is not a sign of a strong human. And whereas you're saying it's a very natural phenomena. Do you yourself get involved, or do you ask the chaplain, religious, or social worker to help you out with that?
We work as a team, and I think it really depends. I think teams manage these things these difficulties in different ways. I've worked in the past with, for example, a social worker who was just such an incredible communicator with the family and would sit for long periods of time to work through these kinds of difficulties and emotions. It's never one of our jobs, and I think sometimes the physicians on the team, on a palliative care team, may be more involved in making some decisions about symptom management and relief. And it may be in some of those cases that our social worker or our chaplain has really an incredible relationship with some of those family members. You know, the bottom line is we do it together. And it's really crucial that we have different skill sets and that we have different backgrounds, because our patients are diverse in the cultures that they come from, diverse in their religious perspectives, in the illnesses and experiences of illness that they have. We need teams that reflect some of those perspectives.
You brought another point in, and that's diversity, and how we come across cultures that probably sometimes you've never heard of, and people from abroad, especially when they come in and they're sick, and then you're very sensitive towards their feelings, but yet you could be doing the right thing and it could be very wrong, and the wrong thing could be right. Not to mention where our intentions are always good, but being sensitive to their beliefs, whether you agree with them or not, is very essential. I'm gonna let questions come in. There are quite a few of them, and I'm gonna try to sort of like address them in our rhythm. Jeremy wants to play the palliative care, so we'll just give an intro to that so we can sort of touch on that topic and then get the expert's view on palliative medicine.
Just hearing the words palliative care can be scary. When a doctor says the person you're caring for would be helped by palliative care, you might think that means they'll pass away soon, but that isn't always the case. In this video, we're going to talk about what palliative care means and how it can help the person you're caring for. Palliative care is a special plan of care that is meant to relieve pain, provide comfort and dignity, and improve the quality of life of the person you're caring for. This special care plan is put in place when a person has been diagnosed with an illness that is life-limiting or terminal, but it doesn't mean that they are actively dying. Palliative care can be added to a treatment plan when someone is in the early stages of an illness and is still receiving treatment to help or cure the illness they have. Being diagnosed with a terminal illness affects the lives of the person with the diagnosis and their caregivers, family, and friends. Palliative care is meant to help with the physical parts of their illness, as well as help with the emotional, spiritual, social, and cultural needs of each person and their family. There are 4 main goals of palliative care. Number 1 is pain control. Doctors, nurses, and pharmacists will work together with you and the person you're caring for to come up with the best plan to make sure they're not in pain. Number 2 is managing other symptoms of their illness. This can include nausea, vomiting, loss of appetite, having a hard time breathing, or confusion. Other healthcare team members like dietitians or respiratory therapists may also help with the care plan here. Number 3 is helping make sure that the person you're caring for and their family, friends, and caregivers' emotional needs are met. This can include speaking with a therapist or a religious or spiritual leader. Number 4 is support for you as their caregiver. Helping care for someone through a terminal illness can be all-encompassing and really overwhelming. You'll need support. Palliative care services can help get you home care support, training on how to do things like give medications or changing a wound dressing, or access to volunteer relief programs so that you can go out and get groceries, take a bath, read a book, and know the person you're caring for will be supported when you take a much-needed break. Having palliative care services will help make sure that they are supported completely, which helps reduce worry, stress, and fear.
So that Khan sets the stage for palliative medicine. I'm going to ask you to just give us your perspective, just an intro brief about palliative medicine.
I had a brilliant social worker, like I mentioned, that I used to work with, and I remember she always said to patients when she was trying to explain what is palliative care, it's an extra layer of support. You know, our task is often to figure out what the patient's needs are, how to control their symptoms in a way that helps them live as well as they can, and maybe adapt to their new situation. So an extra layer of support is a good way to think about it. In some cases, of course, things could be very short, or this kind of difficult news could be very precipitous. But in conditions like dementia, the challenges of understanding a person's perspective and their wishes for treatment and of managing decline can really be a challenge for several years. And 2/3 of us will have difficulty with basic functional challenges. So palliative care gets involved at different times in those journeys for people, but the struggle can be a very long one, or maybe a challenge that's pretty short, just depending upon what the illness is.
So let me ask a few of the questions that have come about. When would you say is the time someone should get palliative care support?
That's a great question. I feel like some of the issues, like outlining who should be involved in a conversation when you're very sick and can't take care of yourself, or can't speak for yourself, rather, those conversations are ones that the doctor's taking care of you over those years of living with an illness should be attending to. I think also understanding a person's basic values and goals is not necessarily the task of a specialist consultant. You know, we do tend to get involved when those conversations are really difficult for people. The situation you mentioned where family members don't agree, or whether there are other sorts of challenges, like a person doesn't have someone to represent them, but they also are incapacitated. So we tend to get involved in maybe hospital settings more often, or conversations that require more expertise. But basic parts of it should be attended to by your oncologist, or your pulmonologist, or the nephrologist who's caring for you on dialysis. Those sorts of clinicians, as you know, are caring for patients who have really challenging prognoses, maybe not in the very short term, but really have significant underlying conditions with symptoms. And so the basic discussions should not be delayed. So challenging symptoms, challenging conversations, transitions, those are situations where we are almost certainly going to be involved, especially in the hospital setting.
When should I trigger the hospice button and make sure and have that as a part of my treatment?
So hospice is a particular type of service that provides care mostly at home, although hospice does have other things like respite when the caregiver needs a break, and there are inpatient facilities for hospice when a person requires care that is too complicated to provide just in the home. Then hospice is really a wonderful choice and a wonderful way to get support.
What are the changes that you are seeing, or upcoming changes in the field, and how do you see that this will change in the next 10 years, but especially in the age of AI?
I think the other part of care that's changed is the use of telehealth. And while this has been a phenomenon across medicine in general, especially after COVID, it's increasingly an important part of caring for us when we're frail, because we face very limiting circumstances, as I've already mentioned. And so telecare or telehealth is really important, as is home-based care. And I think the other part we've also touched on, which is diversity in medicine. Having read a little bit about Islam and understanding the perspective of Muslim patients and families to a degree, I really feel like it's important to be an advocate for yourself too, to let your providers know what needs you have. And one of the things that's really important for providers to recognize is that every person comes to these places in life on our own terms. So it's important to recognize commonalities and aspects of one's faith or religion, but also to recognize that we all are individuals and need to be respected as such.
And whether the beliefs are you're from a Muslim background, Christian or Jew background, we are always sensitive, and you build that rapport relationship with the family, and we always as physicians keep that at the back of our minds, how we're gonna navigate, and you're gonna make the decisions. But at the end of the day, the point you brought about is the patient has to be, or the family has to be an advocate for themselves about how they're going to bring about that change, or how they're going to bring about that plan of action. So really appreciate that comment, which sort of like helps a lot. What do you think about different groups, support groups that help people navigate situations emotionally?
I think most communities these days do have some resources in this regard, and there is some flexibility in the settings and ways in which it's provided. So you can go on websites like the Center to Advance Palliative Care, and I think you can sort of find a directory which can help steer you to some of these resources. Organizations like the Alzheimer's Association also these days have some information about these kinds of services and care. So I think the first step is to be aware, and the second step is to look for it. And I would have high expectations.
First of all, want to welcome Imam Nadeem from Epic Masjid. He is one of the imams who is a pioneer in the masjid development and deals with the youth and other issues. Imam Nadeem, welcome to the podcast, and thank you for coming in and answering some of our questions. We want to like some clarification is, what's Islam's perspective about the process if someone is dying, and should a Muslim, that is the person or the family, be spiritually prepared for the end of life?
So the answer is yes. So for a Muslim, there's, theologically speaking, a Muslim always is aware of the fact that life is something that eventually will come to an end. And when that time comes, of course, we need to understand that this is God's choice. This is not our choice. God has determined our time to come on this earth, and He has also determined the time when we leave.
Nadeem, right, one of the things I want to clarify this, we are here clear on the palliative and end of life. This is no ambiguity. There is no ambiguity about this. We discussed this through its end of life. It's a classic example is metastatic stage 4 cancer. Patient is half unconscious, half already gone. Doctors are saying his heart is not functioning. So what is our Islam perspective about at that stage, when at that juncture, when everyone is clear, but yet the family holds on to saying, oh, he's a Muslim, he's supposed to fight? So that's the question.
So if you're asking about a situation like that,
sure.
Islam says that if all the options have been exhausted,
sure,
doctor is saying that the heart is failing, no matter what you do, nothing's going to solve this. In that situation, a Muslim needs to learn how to let go.
Brilliant. And I think that's sort of answered the question. Let me go to the next similarish question, Imam. How does Islam? We wanted to first of all see if there's a yes or no, and you answer the question. Islam is not against that. Actually, Islam believes in it too. How does Islamic tradition view the concept of suffering and illness as someone approaches the end of their life? Again, it's end of life, and they're going through a suffering. A classic example, again, I'm putting in the cancer example. What would the Islamic traditions view that concept as? And would you give us some clarity on what happens when the patient is suffering and his illness is going beyond the stage where normal therapy is not able to sustain? Is palliation a right approach in that situation?
Yeah, so in this case, once again, we are assuming that all the options have been exhausted.
Of course,
here, okay?
Of course.
In this case, the Muslim family needs to understand that putting the patient through unnecessary pain, because it's not just unnecessary pain. You're going to give them some kind of medication that will perhaps lower the pain or subside the pain momentarily, but it's going to again resurface, and it can resurface at a higher level. In this case, if all the options have been exhausted and there's no hope down the road, then in this case, the family needs to understand that letting the patient go is in the best interest of the patient.
Oh, that's a brilliant answer. And you've answered it in simple terms again to the audience, because they need to understand Islam does not forbade that. And that's
now,
another.
I want to just give another example, because this happens often. I was called here, there was a hospital here, you know this, Dr. Amir, Methodist Richardson Hospital.
Yes, sir.
Okay. I was called over there because there was a family there. There was a boy in their family, a very young guy in their family. Okay. Something happened. I don't want to go into what was the cause, but he was brain dead. Okay.
Yes.
Now I know you are doctors, you know more than me. Okay?
Correct.
But a person who has been brain dead is done. Okay. There's no force.
Correct.
Okay. In that case, the family kept on saying, we're going to transfer this patient to New Jersey. Let's transfer this patient to here.
A very common scenario for doctors.
Very common scenario, right?
Yes.
And they kept on holding on to the fact that miracles exist. Miracles exist. So what happened was, as a religious leader of the community, I went and I explained to them very clearly that this is not a situation where you need to play around with anymore, and you need to learn how to let it go. Now, interestingly, there was a Muslim female doctor there too, okay? She explained to them the same exact thing. Learn how to let it go. This is God's divine decree and his decision. It has happened. You need to learn how to let it go. And this is very typical. We all know the 5 stages of grief. One of them is just compromise and so forth, right? So they're just trying to delay the process and just accepting the truth and accepting the reality.
Absolutely.
And interestingly, I got a call that same night that the family has accepted, and next day we had the funeral service at the mosque. You understand?
That's the most respected. That's
what happens is that sometimes they just cannot learn how to let go. It's just too painful, and that's why sometimes you need a religious leader to go and tell them this is not worth fighting anymore. You're putting the patient in more serious danger, more serious pain. You are sitting over here painless, not understanding what his or her pain is. In this situation, you need to learn how to let it go.
I just want to thank you very much, Imam Nadeem, for coming in and answering the major questions. We've got some interesting other questions, however, opened up, and I would love to have you back again, and we'll talk about it next time, hopefully in a different sort of situation where we can see you as well and complete the rest of the discussion. Have a good one. Thank you.